So when I was told that I need to speak about hypertension, at times it just happens then when you are practicing a different kind of a specialty, my specialty being interventional cardiology, hypertension is slightly different topic. But let me assure you that I'll try to do justice to this. Although having said that, I mean, everybody talks about this hypertension. So why should we keep talking about the same old thing? Just happens that people start yawning when you start speaking about hypertension. Some people start dozing off, and some people actually go off to sleep when you talk about hypertension, because it's rather boring topic to be discussed in an academic forum. So why should one talk about the same old thing? The reason is very, very apt. In my cardiology practice, and as my cardiology friends would bear me out, this is the commonest diagnosis that we see every day, in and out. Every other patient has got hypertension. Especially since 8th of November, probably the entire country is suffering from hypertension. So those above the age of 55 with a normal blood pressure will have a 90% lifetime risk of developing hypertension. So all those who are 55 now can imagine that at one point of time in their life they will develop hypertension for sure, 90% chance. Approximately 70% of the patients who develop their first heart attack or first stroke or come with a heart failure have an underlying blood pressure of more than 140/90. So that is the importance as a risk factor of hypertension. It is common to stroke, heart attacks and heart failure. More than 70% of the patients have it. Beginning with a blood pressure of just 115/75, as was told to us in JNC 7, cardiovascular risk doubles for each increment of 20/10. Just if it goes from 115 to 135, the cardiovascular risk has doubled in that period. 30% of the adults are unaware of their hypertension. 40% of the individuals with hypertension are not on treatment or not adhering to the treatment, and 2/3 of the patients on treatment are not controlled to blood pressure levels of less than 140. This is despite the fact that we cry hoarse that blood pressure has to be controlled. It has to be controlled not with one drug, if possible 2 drugs, 3 drugs, whatever it takes, you must control your blood pressure. People are still very ignorant about hypertension, and hypertension is taken very, very lightly and any other disease. So hypertensive patients are 2.5 times more likely to develop diabetes within 5 years. So this is something which is a recent data which has come up in the last 10 years, that hypertensives are prone to diabetics. So if you are a normotensive, your chances of getting diabetes are much less as compared to if you are a hypertensive. When we talk of hypertension, as I said, that since 8th of November, probably 90% or 100%, I should say, of adults are suffering from hypertension ever since the demonetization has probably occurred in the country. Some are probably trying to get rid of the money, and some probably getting in lines and queues are also getting hypertension. But what are the figures for our country? We just keep talking about the Western figures. Let's have some figures from our own country. So this is a study which was conducted in India, and it shows that it's an epidemiological study. 33% of the urban, 1/3 of the urban population as of today, and 25%, 1/4 of the rural population suffers from hypertension. 25% of the rural and 42% of the urban Indians are aware of their hypertensive status, but 25% of the rural and again 38% of urban Indians are only being treated. So there is a huge chunk, huge mass, given the size of the population that we have in our country. You can imagine how many patients of hypertension are going untreated as of today, who will end up with probably heart attacks, cardiovascular strokes and heart failure in future. You can just imagine the mammoth proportions of the number of patients that we are going to see in the near future. And this is again the prevalence of hypertension in 214. It's a very striking data. If you see north, east, west or south, India has got one of the highest figures of hypertension in the world, whether it is rural or whether it is urban areas. So what is the lifetime risk of developing hypertension beginning at the age of 65? As I told you earlier also, it's about 90%. So if you are normotensive to begin with, maybe even at the age of 55, you have a 90% chance of developing hypertension. So this is just a little background about hypertension and the amount of disease that we are faced with and the mammoth proportions of these kind of complications that we are likely to see in future, not to forget the renal complication and the ophthalmic complications which come along as a package with hypertension. So the disease may sound simple, but it's not simple because there are so many controversies surrounding the topic of hypertension. Right from the beginning of the definition of hypertension to how to control the blood pressure, which guidelines should one be following, which blood pressure is more dangerous, is it systolic or diastolic? Although having said this, I mean, this controversy is over, but still there are patients and still there are physicians who still believe that diastolic blood pressure is more important. Which drug to be used, when to be used, which drug is not to be used, what is the best time to give the therapy, and is there any other method of controlling blood pressure besides the drug? So there are a lot of controversial issues, and if I keep talking about all of them in detail, probably the entire night is going to go. So it's a topic which is marred by controversies. The first and foremost being what is the definition of hypertension. In fact, we have all read, and probably it continues to be written, that it's an essential hypertension. Essential means that the cause is not known. But to begin with, essential meant that this amount of pressure is necessary for the body to be generated so that the vital organs are perfused. So that is why the word was coined as essential hypertension. Now it is called a primary hypertension because we don't know the cause in most of the cases, but essential hypertension was like this. And Mr. Roosevelt, who was the president of America at one point of time, he had one of the highest levels of blood pressure which was ever recorded in the medical history. Probably it's gone down the annals of White House that when he died, he had a blood pressure of 300 by 190. This was the blood pressure which was recorded, and he probably died the next day of a brain hemorrhage. So even one of the eminent cardiologists of those times, Paul Wood, used to say that treating hypertension is of no use because blood pressure is required by the body to maintain the perfusion of the essential organs or the vital organs of the body. So there has been controversy from the beginning. What is the level of blood pressure, and how does one objectivize the definition of hypertension in real world? What is my definition of hypertension? What is your hypertension definition? People still come to us with blood pressures of 200 and they say, we are fine, we have no problems, we have no symptoms, so why should I get it treated? Similarly, physicians probably taking blood pressure, somebody has got a blood pressure of 150 to 160 systolic, they will be told, oh, this is okay, I don't think you should worry, just cut down on a little bit of salt, this is okay. So the sloppiness with which the definition of hypertension is dealt with is also alarming at times. So how does one objectivize the definition of hypertension in real world? We have to appreciate and accept the linear relationship between blood pressure and cardiovascular events. We know that the increase in cardiovascular event occurs linearly with the rising blood pressure levels. Very important to understand. And all this despite the fact that we lack the data from randomized controlled trials to know the ideal systolic blood pressure for reducing cardiovascular events. As I would like to point out in the subsequent slides, there is a lot of controversy which is the correct level of blood pressure at which the person needs treatment and what is the extent to which it should be reduced. We have also to consider the value of systolic blood pressure as the main target in the treatment of patients above 55 and to consider the 20% relative risk reduction benefit using RAAS inhibitor, that is the renin-angiotensin inhibitors. So what is your definition of hypertension? It may be different for different people. So has the time now come that The definition of hypertension should be customized according to the patient, as we have started doing in most of the diseases. For example, in cases of lipids, in lipids we customize the definition of dyslipidemia to a large extent depending upon the comorbid conditions of the patient. So similarly, do we need to have a definition of hypertension in which we factor in different comorbidities of the person? I think the time has come. So based on these facts, we should replace the word hypertension, as it cannot have one size fits all, and the blood pressure goal should be established for each patient, for example, as shown in this cartoon. The second important controversy which arises around blood pressure or hovers around blood pressure is the blood pressure management, is the measurement of the blood pressure. I think Dr. UP Singh is sitting over here. I have heard him so many times discussing how to record a blood pressure. I mean, it may sound ridiculously simple, but I can tell you that this gentleman, Dr. Norman Kaplan, has spent his lifetime investigating and conducting trials of hypertension. And still he said that the measurement of blood pressure is the clinical procedure of greatest importance that is performed in the sloppiest manner. And it's absolutely true. You turn around and look at the way blood pressure is recorded in this country. And poor blood pressure measurement technique may be associated with elevated blood pressure. Now, elevated blood pressure, in quote unquote, if you see and you start treating it aggressively, then you are likely to produce more problems than good to the patient. Similarly, I mean, a blood pressure which is recorded as low or probably normal in an individual who's got a high blood pressure probably is going to do the other way around. So it's very important that blood pressure measurement should be taken care of. There are actually people have worked out what is the effect on blood pressure if certain things are done or not done in the clinical practice. And actually they have worked out that it requires about 8 to 11 minutes time if you want to really record a blood pressure correctly in an individual, if you want to treat that individual. And these have been listed over here. Someone wants a reference, I can give it later. There are Indian guidelines also available now. Fortunately, Indian guidelines are coming for everything, and there are guidelines now available for hypertension measurement also in our country, and these are hardly ever followed. If you see in your own clinical practice and if you see how you record the blood pressure, probably introspect, you will find that our recording of blood pressure is still very, very inadequate and leaves a lot to be desired. There are three kinds of blood pressure recordings which are available today. Somebody comes to your clinic, it's an office blood pressure which you are recording. You ask that person to buy an automated blood pressure instrument and keep recording at regular intervals at his place. This is called a home BP recording. And the third kind is an ambulatory blood pressure monitoring, in which a blood pressure monitor or a small monitor with a cuff is attached to the patient over a period of maybe 24 hours to 48 hours according to the requirement of the person or the clinician. And then it keeps recording the blood pressure intermittently, and you create a graph and get information about the blood pressure levels and their variations. So these are the three different kinds of blood pressure readings which one can get in clinical practice. Now the person comes to you in the clinic, you measure the blood pressure. This is office blood pressure recording. So what are the challenges if you are going to take clinical decisions based on the first contact with the person who has got one blood pressure recording? You have got insufficient number of readings, plus there could be an inherent variability in taking the blood pressure, as I just told you. There could be a poor technique, which could be because of the poor kind of blood pressure apparatus you may be having, which may be leaking, which may not, the cuff may not be of the correct size probably, or it's not tied properly. Then there are two important things which can happen. The white coat effect, we all know that the blood pressure of the patient rises when he comes to the clinic/hospital. But there is an opposite of that also happening in some individuals, which is called the masked effect or the masked hypertension. Masked hypertension is when the clinic hypertension is less than 140 millimeters of systolic blood pressure, but the person goes home And he comes back the next week, he says, "Doctor, my blood pressure at home is always elevated. It's more than 135, it's more than 150. You check the blood pressure, it's less than 140. You tell the patient, you are not suffering from." So this is masked hypertension, which is opposite of white coat hypertension as it occurs. So these are the two important things which you cannot decipher most of the time in an office blood pressure setting, because you're taking just one reading or maybe a subsequent reading after a few days. Again, there is a lot of controversy regarding the devices. The good old mercury manometer has been abandoned, has been banned in the country because of the mercury problem. And so as of today, the most recommended devices are the oscillometric method of recording blood pressure. And these are far and few. Most of the times these are not available in most of the clinics and hospitals even today, and because the standardization is still not there. So just talking about white coat and masked hypertension, I told you the definition of the two, and this is how the curve looks when you look at masked hypertension and white coat effect. White coat effect is when the blood pressure is more in your clinic. Masked hypertension is that the blood pressure in the office is fine or the clinic is fine, but the person goes home and his blood pressure rises. So these are the two important things which need to be settled, and they cannot be settled just by an office reading. So these are the key highlights of the three different kind of blood pressure measurements that you can have. That is the office blood pressure measurement. It is a time proven measure. We have been taking it for years together, not us, even our predecessors have been taking it. It's easy to perform and widely available. Whereas the home BP monitoring, home BP is the person takes it himself with a device or somebody in the family takes it for him. It's more reproducible than office blood pressure simply because you are taking many more readings. Assessment of white coat hypertension and masked effect can be made on the basis of these recordings. Although no hard-cut outcomes through clinical trials, but consistently it's a better marker of organ damage and prognosis in observational studies. But it definitely improves the adherence of the patient to the medicine. It sometimes, having said that, it sometimes have an opposite effect also, because the patients become anxious and their readings actually go haywire at times. And they can be a pain in the neck, because every time the blood pressure increases by 10 millimeters, he is going to call you on the mobile. "Doctor, my blood pressure has gone up from 140 to 150 today. So what should I do?" So this is slightly a pain in the neck at times. And 24 hours ABPM, ambulatory blood pressure monitoring, can be very, very helpful in assessment of sleep blood pressure, morning surge and blood pressure variability. It is required for diagnosis of hypertension. Have you heard about that? That now it is becoming mandatory through some of the associations. The diagnosis of hypertension should be made through ambulatory blood pressure monitoring and not through office recordings alone. Because out of hospital or out of clinic recordings or non-office recordings are a better predictor of cardiovascular events than office blood pressure. It is now a well-established fact. And hence, the US Preventive Services Task Force draft recommendations, there is a change from 2007. In 2007, it used to say that for adults, it recommends screening for high blood pressure in adults in age 18 years and older. New guidelines of 2015 now say that all adults 18 and older use office blood pressure as a screening test and then confirm the diagnosis with out-of-office blood pressure recordings prior to initiation of antihypertensive therapy. So this is a very major change which has now come in, and I think in future we have to adopt this change, because it definitely correlates much better with the blood pressure recordings. And not only this task force, there are other associations which now recommend to confirm the diagnosis of hypertension. For example, the Canadian Hypertension Education Program 2015, NICE guidelines from Britain, and European Society of Hypertension position paper on ABPM in 2013 all recommend the use of ABPM technique to make a diagnosis of hypertension. You can screen the patient with your office blood pressure. So coming to the guidelines, as I was just talking about, there is a huge controversy regarding the guidelines of hypertension, which guidelines to be followed. Somebody says something, the other says something. The most commonly used guidelines are the JNC 8 guidelines. Unfortunately, JNC 8, which was set up by American Heart Association, the American Heart Association itself doesn't endorse that. And JNC 8 panelists had to go to JAMA to get this published into after 8 years of long deliberation. And there were a lot of people who were discontented within the panel itself with the guidelines, and they gave their own set of recommendations. Anyway, what it suggests is that for any person above the age of 60 years, the blood pressure should be treated when it is more than 150/90, and it should be brought down below 150/90. For people below age 60 years, it's 140/90. The previous guidelines of JNC used to say 130/90. Now it's 140/90. So they have upscaled the level at which the blood pressure needs to be treated and the target blood pressure. And interestingly, very, very interestingly, it was just based on 2 trials from Japan. 2 small trials from Japan, which they accepted as the gospel truth, and they said that there is no evidence to show that there is a difference between 140 and 150. So why waste public or taxpayers' money in treating patients to 140/90? So 150/90 is good enough on the basis of 2 Japanese trials. So let's accept that. And there were a lot of controversy regarding these trials. I've just told you what they say, except probably that it still recommends that in all adult patients with diabetes or chronic disease, start medication at blood pressure of 140/90 and treat to goal of 140/90. Again, this is a controversial issue because the diabetologists do not accept this, the kidney people do not accept it, the nephrologists will not accept it. They would still say that it should be less than 130/80 or something like that. So there are multitude of hypertension guidelines which are still available in the market and which have been published, and we really do not know which one to follow. If you compare these different guidelines, whether it is the JNC 7, 8, ASH, ESC guidelines or SHEP guidelines, you will see that those things marked in red are differing from one guidelines to another. The harshest is probably still the JNC 8, which still says for most of the individuals it has got to be 150/90 if the person is more than 60 years of age. So you have guidelines from AHA's scientific advisory which says that, which came in 2014, all persons irrespective of age less than 140/90. Another statement by American Society of Hypertension and International Society of Hypertension, again 2014, it says that anybody who is beyond 80 years of age or more, it should be less than 150/90. Diabetics or CKD less than 140/90. You just get confused which kind of guidelines you need to follow and what is the level to which it needs to be treated. Again, another guideline which says that a stable patient less than 140/90, prior MI, stroke or TIA less than 130/80. Standards in medical care in diabetes, it says that all diabetics less than 140/80. And then we have a recent trials which have come in 2016, which are, I call them flip-flop trials, because one of the trials shows something, the other trial shows something else, probably a SPRINT and HOPE trial. The SPRINT trial was one of the largest trials of the two, and it tested whether the treatment strategy aimed at reducing systolic blood pressure to a lower goal. It says that you bring down the blood pressure below 120 rather than the recommended 140, and see whether it is good or bad for the individual. Will it reduce the occurrence of cardiovascular disease? And it shows that intensive treatment arm had 25% less risk of primary outcomes. And interestingly, the numbers needed to treat were just 61, which is not huge compared to the size of the population that is suffering from blood pressure. Very interestingly, safety outcomes from this trial. Safety outcomes, they showed that if you aggressively treat blood pressure and bring it down below 120, you find that there is increased incidence of acute kidney injury or acute renal failure. They couldn't ascribe a cause, they couldn't say whether it is good or bad and what is going to be the prognosis of these patients, but they definitely had this finding that people whose blood pressure was treated to less than 120 had higher incidence of kidney disease, acute kidney disease. So overall, benefits of more intensive BP lowering exceeded the potential for the harm, and equally important is that there should be an alert implications for following a sprint in our clinical practice. These two trials which have come in 2016, about which I am talking, these two trials laid a huge emphasis on how the blood pressure is recorded. And so was the case with the sprint trial, in which the blood pressure recording criteria were very, very stringent. If we do not follow the criteria which were followed by sprint, what is going to happen is that without attention to proper blood pressure measurements, substantial over-treatment is likely to occur, because more and more people will fall into a category of hypertension, maybe with a blood pressure of say 145 to 150, you start treating them with one recording. If you have not checked the blood pressure at home or through an ABPM and confirmed it, and then you try to bring it down to 120, something should raise an alarm, because less than 120, the person has a risk of acute kidney injury. So what I need to say is that these trials have emphatically said that you must record blood pressure very, very accurately before starting the treatment. And now HOPE 3 BP trial was an absolute opposite of this, although I must add that the subtypes or the subgroups of these, or the subjects of both these trials, were different. In this, the hypothesis was that people with intermediate cardiovascular risk means 1% risk of developing a heart attack or probably a CVA per annum. And are these patients with a blood pressure which is normal or maybe slightly high, for example in the range of 140 to 150, if you treat them with hydrochlorothiazide or candesartan combination, will it reduce the cardiovascular events? These are the patients who, according to JNC 8, should not be treated probably, because it's 150 by 90 probably. But these patients were included in this trial. So what did this trial show? That there is no effect, there is no added advantage if you treat these patients aggressively. So no significant differences in individual components of the outcomes, total mortality and new onset diabetes. The only advantage that was seen was in the highest tertile, that is the patients who were having blood pressure beyond 143 and above, that there was some definite benefit. Otherwise, less than that, no use, no benefit of treating these patients. So again, this trial the emphasis was on blood pressure recording management. So we have two trials coming in 2016. One of them says that treat aggressively, bring down the blood pressure to less than 120 by 80, it helps the patient. The other trial says that we don't know, probably it doesn't help. So again, we are left from where we started. So it's difficult at times, to follow the guidelines. However, there are comments from the authors of HOPE 3 trials which say that our findings contradict the lower is better hypothesis. Our data are compatible with the hypothesis that treating persons without cardiovascular disease, most of the patients that we see are sometimes falling in this category, only hypertension, no diabetes, not a smoker, no cardiovascular disease, because these patients are suffering probably from a lifestyle disease. Persons without cardiovascular disease who have systolic blood pressure above 140 millimeters appear to be beneficial, but treatment would not be of benefit and may be even harmful in patients with lower systolic blood pressure. So it's very important, again going back to the basics, you have to have an ABPM recording, you have to have an out-of-office recording and multiple recordings before you put these patients on treatment. What is chronopharmacology? When should the antihypertensive medication be prescribed? There is some controversy regarding this also, whether it should be given in the morning, afternoon, evening, night. What is the best time to give an antihypertensive therapy? If we go by physiology, then the physiology says that the maximum blood pressure is recorded early in the morning, and the early morning surge has to be suppressed somehow so that it is responsible for the cardiovascular events which occur early in the morning. It is one of the contributors towards that. But not every trial has shown that. There was a trial in 2010, the MEPIC trial, in which they had a 48-hour ABPM data, showed systolic blood pressure with the evening dose. So, and there was a lower risk of total cardiovascular events with evening doses. This was one trial which has shown that instead of giving it in the morning, if you are giving one single dose to the patient in 24 hours, it is better to give in the evening rather than in the morning. And so the Cochrane review of 2011 accepted that better blood pressure control with bedtime dosing, the clinical significance of which is still not known because we need more trials, and no RCT till date tells us whether morning or evening is better. These are just observational studies. Is there anything else we can do besides pharmacotherapy or medicines in this? Yes, renal denervation therapy had come in a big way about 5 to 6 years back, when at least people like us who were doing interventions, coronary interventions, were quite excited because the first trial, which was the Simplicity trial, showed a lot of benefit in resistant hypertension cases. How does it work? The sympathetic nerves around the renal artery are subjected to radiofrequency ablation. Once the sympathetic drive around the artery goes, the artery dilates, and this causes the lowering of the blood pressure in the kidney, thereby causing decrease in the hypertension which is caused as an effect of renovascular system. So the first trial, which was Simplicity 1 trial, was a positive trial which did show a lot of benefit in these patients, but somehow the trials which followed, in fact the giant of interventional cardiology, Medtronic, which was following these trials and which was very, very upbeat about the introduction of a catheter for renal denervation about 2 years back, had to suddenly withdraw all its products, and they announced that it's going to be a multi-million loss to the company, but they are withdrawing it because the trials are not showing benefit of renal denervation as of today. So can renal denervation be compared to medical therapy? Again, we have the Prague trials. Prague always comes to the rescue of so many things because it's a small country, the Czech Republic, and they are able to conduct small trials telling us what to do and what not to do. But unfortunately, the reduction in resistant hypertension, whether you do a complete renal denervation or use multiple drugs, the amount of blood pressure reduction is the same. So as of today, where we stand, the medical therapy is as good as renal denervation. We haven't heard the last about renal denervation, this much I can tell you. Just coming towards the end of this lecture, hypertension still remains a condition of public health importance in the country. There is a consensus to treat blood pressure to a target below 140 by 90 in most of the patients, except diabetics and patients with chronic kidney disease. It's extremely important to measure blood pressure accurately to diagnose and treat hypertension. Again, I would emphasize, I think the keynote of this address is this. An ABPM is a very useful tool in certain conditions and should be used more and more. Unfortunately, it's highly underutilized tool as it. Choice of drugs for controlling blood pressure should be individualized according to the patient, as we have started doing in most of the cases. Until more data emerges, evening dose of antihypertensive can be advised, although we still don't have data. Thank you so much.